Good evening, all, and welcome to the new series started by MUS for especially for the UCAM members. We feel it is imperative that you stay in constant touch with academics. The only reason we feel is if you're not actually doing MSK ultrasound on a daily basis, it can get evaporative and you might feel out of touch. So to ensure that you are well within touch and you get we will make sure that we keep updating you on time to time. And doing the honors today with a very interesting topic is Dr. Nidhi Bhatnagar. Uh, I mean, I don't need to introduce her. She has been the pillar, in fact, the founding member of MUS. And it is because of a zeal that we are where we are today. And she has that passion of teaching and continuously updating herself with the latest articles, which she ensures that she shares with us so that we don't lag behind too. And I'm sure this is going to be a wonderful webinar. Over to you, Nidhi.
Thanks, Mohit. Hi, good evening, everyone. I'm just sharing my screen here. Okay. So there are some speakers
Can I
that are on.
request everyone to keep their thing on mute, please? Everyone, please stay on mute.
Okay, so hi, everyone. Once again, thank you all for joining in. It's a great honor and a privilege to have such esteemed people in our MUS UCAM courses. And I have to thank Ankit for curating this program. Thanks, Ankit, for doing so. But the initial idea had come from Mohit and Rajas, and we have been brainstorming through last 3-4 months how to create something unique for our UCAM delegates and UCAM now graduates. So here we are today with Trigger Finger. And before we go on to a formal discussion, here is a little question for you. You can put your answers in the chat box. What is the primary structure that is involved in trigger finger? Is it the A1 pulley, flexor tendon sheath, flexor tendons, whether it's the superficialis or profundus, A2 pulley, or something called as Camper's chiasm? So you can put your answers in the chat box. And I'm sure that Rajas will have a look at it and let us know what the majority says. In this meantime, here is a grayscale static image. And what is it that we'd like to explore when we are presented with a case of trigger finger? So we'd like to see the annular pulley, whether it's A1, A2, A3. We'll go on to discuss why. So it's the annular pulley, the thickness, and its echo pattern. We'd like to also see for the tendons, this tendon complex of superficialis and profundus, the thickness, the diameter, and of course the echo pattern. Then the metacarpophalangeal joint with its configuration with Waller plate, and most importantly, the tendon sheath and the pulley interface. But of course, the basis of the diagnostic sensitivity comes with what we call as the dynamic scan. Now, in the dynamic scan, we must understand what it means to be having unrestricted, free movement of the flexor tendons. And you have to just keep this in mind, because when we go through the presentation, you will be asked to recall this synchronous movement of the flexor digitorum, superficialis, and profundus, moving in tandem with each other with the flexion extension of the finger in this fibroosseous tunnel, which we call as the annular pulleys. Here it is the A1 at metacarpophalangeal joint. More importantly, it is to see that there is no imprinting on the flexor tendon complex. As you can see here, the surface of the flexor digitorum superficialis is absolutely smooth, the contours are regular, and there is no compression or imprinting from the superficial structures. Now, this is a really important sign. Rajesh, can we know what has been put in the chat box? What does the majority say about the primary structure involved? You have an answers there? Can you hear me? Hello? Mohit, can you hear me?
Yes, ma'am. Majority of answers are A1 pulley.
A1 pulley. All right. If that's the A1 pulley, thank you so much. We are going to go to the definition of trigger finger. I'm going to just stop this. And the definition is that trigger finger is a type of stenosing tenosynovitis. This is a bit of a misnomer, I'm sure. Whoever has been researching tenosynovitis and stenosing tenosynovitis knows that there is no synovium, there is no tendosynovium. It is just the tendon sheath on histopathology. However, we'll continue to call it stenosing tenosynovitis for ease of discussion. And it involves the flexor digitorum superficialis tendon, along with A1 pulley. So at the level of flexor digitorum superficialis tendon and A1, here it is A1 because majority of the studies have said that maximally involved is the A1 pulley in trigger finger, and also that in 100% of the cases of trigger finger, it is the pulley, the annular pulley. So we are all confirmed on this that it is the A1 pulley and the flexor digitorum tendon sheath. What comes first? Before, of course, we go on, there are other kinds of stenosing tenosynovitis. I'm sure that each one of you knows that for the fingers, it's called as trigger finger, but then we have decurrens, we have extensor carpi ulnaris in the retinaculum, extensor compartment 6, or of course, we have of the peroneal tendons, so on and so forth. So what comes first? Is it the A1 pulley that causes the trigger finger, or is it the flexor tendon sheath that causes A1 pulley thickening? The consensus is that it is we exactly don't know what the reason is, whether it is trauma or it is inflammatory diseases, arthritis, something like rheumatoid arthritis, diabetes, hypothyroidism. But one thing is sure, that it is an overuse syndrome. We are all confirmed that it's an overuse syndrome with continuous movement of the flexion and extension of the fingers, which causes the repetitive movement, micro traumas in the tendon sheath. There is an irritation, the swelling, it can have tendon sheath effusion, and when it goes through that chronicity phase, it becomes contracted, thickened, and starts causing what we call as a trigger finger. So where does the A1 or the pulley, any annular pulley, gets involved? The cause is the conflict that is there between the tendon sheath, and when it passes through that annular pulley, the constant rubbing of the superficial sheath at the level of the flexor digitorum superficialis and the deepest layer of the pulley. Now, this deepest layer of the pulley is very interesting. The superficial layer is vascular layer. That is where you raise the tenosynovitis, that inflammatory response, that color Doppler, that neovascularity, which is also one of the very important parts or hallmarks of tendon sheath synovitis or trigger finger developing. But the deeper layer, it has been shown in histopathology to have fibroblasts, and it has chondrocytes, as a result of which, when there is this conflict and it's very closely invested with the tendon sheath of the superficialis, and that leads to the reactive thickening. And this thickening is really extremely tight thickening that happens at the level of the annular pulleys. Now, this is, of course, eyeballing here. And when you're seeing it, you know that there is a thickening of the annular pulley sitting here. Right here, it's the A1. For the sake of description, we can say that thickening of millimeters. Okay, this was like 0.7 millimeters, and this thickening leads to what we call as the typical tenosynovitis. Hussaina, I request you to please mute. Request you to please mute, Hussaina, everybody. Thank you so much. All right. So this thickening leads to a kind of restrictive and a tendinosis effect of the flexor tendon complex, as you can see here. So the concavo-convex configuration of flexor digitorum superficialis, this is a normal configuration of flexor digitorum superficialis. It is concavo-convex, or it's oval with the underlying surface as flat surface.
Just a minute, Nidhi.
Yeah.
Please keep muted. Sir, please keep yourself muted. It disrupts everybody's attention. Please keep yourself muted.
Thanks, Mohit. So that is the concavo-convex, but there can be a flattening also. Now, when the triggering is initiating it leads to rounding, particularly of flexurorum superficialis. The profundus is not so badly affected, and that leads to increase in the AP diameter. So anytime you come across an increase in the AP diameter and an annular thickening, when you compare it with the asymptomatic finger, you would know that we are dealing with the evolution of a trigger finger. Having said that, let's have some descriptors, some definitions very clear. So there is one thing that is called as triggering, and then there is another thing which is called as locking. Now, these are the signs of the same spectrum of the disease, the pathophysiology of stenosing tenosynovitis, and these are the 5 stages, 6 stages that you can see. So first, of course, is a normal. Another is when the person presents with that painful finger and there is a restriction of movement and we don't know. The clinician does not know whether we are moving towards a stenosing tenosynovitis. But when the triggering starts, and you do know that triggering is a clinical sign, can we convert this into a sonosign? Absolutely. Now, this triggering then evolves into stage 4 and stage 5 that we call locking. Now, locking is the one in which there is a snapping at the level of PIP when there is an extension of the finger. That is a typical trigger finger that our mindset has. But let's have a look at this. This is a patient here, and you can see that this was patient initial stages of triggering where she was having difficulty opening the finger, the ring finger. So you can see that there is a restriction of the opening, extension, but there is no sudden snapping, which we think should be the trigger finger. Anything sitting like this also needs investigation to rule out, are we dealing with stenosing tenosynovitis evolving here? Now, here's this patient, and I'm going to go to stage 5 first. She presented to us at stage 5. This is before the treatment. That means she took a steroid injection in both her pulleys. And let's have a look at this. Now, this is how we have the triggering in our heads. She could not extend her fingers, and she had to passively do it. And look at the middle finger, which goes with a snap, right? Now, if this is not happening, then we think it is not triggering, but it is. And this is how she presented to us, stage 4, after the injection. And now you see the flexion is not restricted, but the extension at proximal interphalangeal joint. So she could do it of the ring finger, but the middle finger again snapped. So this is locking. So we are having locking here, and this is definitely a stenosing tenosynovitis, typically trigger finger, but this is also a trigger finger evolving with stenosing tenosynovitis. So how do we convert this into sonosigns? Let's talk about it. This is a static grayscale image, and of course you can all see that there is an irregularity and thickening of the A1 pulley, which is of course the commonest region to be involved in trigger finger, metacarpophalangeal joint, and you have the flexor tendon complex of superficialis and profundus here. We go on to do our dynamic scan and do take care of 2 things. One is how this thickened pulley changes its form and causing an imprint. Do you see the contour of the flexor tendon superficialis changing its contour? Now, that imprint is where we say that stenosing tenosynovitis, even though this patient is not locking, not snapping, but this patient 100% is going into what we call as a trigger finger. So this is a clinical counterpart of a trigger finger clinically. The second thing is, would you see how there is an asynchronous? This is not a synchronous movement of superficialis with respect to profundus. This is a very subtle sonosign which says this is stenosing tenosynovitis. This asynchronous movement where they are not moving, free, unrestricted movement. This is a movement, all right, but it is definitely restricted with a finger imprinting, with a thickened A1 pulley, and an asynchronous movement of the superficialis with that of profundus. Now, this is happening at the level of A1, this imprint. Let's go on to see another case. And these are, of course, grayscale images. A1 pulley thickened, there is an imprint, and this is how we raise the vascularity, because this patient was now in a kind of evolution of that inflammation, tenosynovitis, and then, of course, moved on to have this imprint. Let's have a look at the dynamic scan, A1 pulley. Absolutely no imprint, but look at the proximal to this A1 pulley. tendon sheath thickening. Here, the tendon sheath is causing that imprinting, and this imprinting is leading to that compressive change, which will eventually lead to locking. But this is a restricted movement on flexion and extension, and you can see that there is a kind of asynchronous behavior of the profundus and that of the superficialis tendon. So this is what we again call a triggering. So triggering is kind of synonymous with stenosing tenosynovitis. This is what we call as the stenosing tenosynovitis at the level of the flexor tendon sheath. A1 thickening. Now, this is a reactive A1 thickening because there's a conflict between the tendon sheath and the tendon movement. So we've already now discussed, we are convinced that A1 pulley thickening with hyperemia or without hyperemia, tendon sheath involvement with effusion or thickening are the trigger points. We are happy saying maximally in stenosing tenosynovitis, and the sonosigns are we should be seen for the fingerprinting, restriction of extension of the digit or the finger, and there can be an associated tendinosis. So are we done here? All right, are we done with this? No, we are not. The purpose of this presentation today is to convince you all that we have to explore A2 pulley and less commonly the A3 pulley, even though we are seeing that yes, A1 pulley may be involved. Then there is a focal nota nodule formation. That means predominantly it happens in thumb in children. Sometimes it's congenital, which again causes restriction of extension. And this is a focal thickening of the tendon. But last but not the least, and this is the fifth point of conflict, and called as at the Camper's chiasm that we'll go on to discuss further. The other reasons why trigger happens. Now, this is triggering. This is not stenosing tenosynovitis. And we should be absolutely certain of what we are narrating to our orthopedic surgeons. So these ganglion sheath, the ganglion of the tendon sheath, flexor tendon sheath, can cause trigger, but they don't cause stenosing tenosynovitis. And just a word on the ganglion of the tendon sheath, if they are present between A1 and A2 pulley, so A1 and A2 pulley, when they are present in between, they had an enormous kind of implication surgically, because those were the times when we didn't have ultrasound-guided interventions and they had to be excised because the finger was triggering. And they used to happen in what we call as the zone 2. Now, zone 2 was considered as no man's land because it's a hypovascular area. And any surgical intervention at this point used to lead to either infections or sometimes avascular necrosis of soft tissue. So the surgeons were very skeptical at that point of time. So it's just a small history for you to, chit chat about at some time later. Now we come to the ganglion cyst of the A1 pulley, and this is where we talk about the two layers, the superficial layer and the deep layer, which is so closely invested with that of the tendon sheath of the flexor tendons. And that's how it causes the thickening because of the constant motion that is present between thickened tendon sheath or the tendinosis and leads to thickening of the A1 pulley. And what we are totally bound by how and when, at what point do we indicate that this A1 pulley might need an intervention? So it's all right when we give steroid injections and we are okay, but when it comes to surgical intervention that you have to do a pulley release, it's easier said than done. Because what if A1 pulley is not the only point of conflict? And you go on and do a release, which leads to, very sadly, a digital nerve getting involved, which is worse than having a trigger finger. So we have to be absolutely sure when we are talking of stenosing tenosynovitis that we are certain what are the points of conflicts that the patient has to be looked for. Then this is the nota nodule that we were talking about, which is focal tendon thickening, more seen in children, resolves on its own in maximum patients after 8 years of age. Surgical intervention is really not recommended early. It's splinting or it is just physiotherapy or stretching exercises. And this is a patient who came to us, and this is flexor pollicis longus tendon that you can see here. I'm just kind of doing the movement so that we keep it under sono view. And you can see how beautiful the echo pattern is, and the movement is kind of free. We are happy here. But going on to the affected side, you can see this is the flexor pollicis, which looks kind of sad. The echo pattern is disturbed. And as we're doing the focal the flexion extension, you can see how this nota nodule pops up. And why does this nota nodule form? This forms because there is a discordance between the growth of the flexor tendons versus the growth of the flexor tendon sheath in the young age. And that leads to constriction of the flexor tendon sheath and the formation of the nota nodule. And you can see here that flexion is not restricted. It is the extension of the thumb that is restricted. And of course, we can always explore the extensor tendon also in order to be absolutely certain. So that is the EPL, and you can see how beautifully it moves at the on the dynamic scan of flexion and extension. There is no restriction of movement, so it is not the extension. Just because the extensor, the extension of the thumb is involved at the interphalangeal joint, it is the flexion is so preserved. It is the extension of the thumb which is restricted by this nota nodule that we need to take care of, and this does cause triggering of the thumb as well. So that comes to my main aim of giving this presentation today, the fifth point of conflict in trigger finger, which is called as Camper's chiasm. And here is just a diagram that I'm going to be drawing. This, of course, starts with the flexor tendon at the proximal phalanx, A1 pulley, A2 pulley, and this is the flexor digitorum profundus tendon, which will be piercing through and splitting the flexor digitorum superficialis. So let's start with it. Flexor digitorum superficialis at the proximal phalanx splits into two slips. Now, these slips actually fold upon themselves so that the medial and the lateral borders are now flipped to the opposite sides. And at the level just proximal to the proximal interphalangeal joint, these two slips actually meet again. They reunite to form what is called as a tendinous chiasm. They decussate. You can see the fibers of both the slips decussating with themselves to form a tendinous pulley on which the flexor digitorum profundus tendon rests. And then at the level of PIP, it kind of splits again to take its insertion at the base of the at the middle end of the middle phalanx. Now, this chiasm, or Camper's chiasm, is again, it acts like a pulley. It's like a hammock on which the flexor digitorum profundus rests and helps it to become more elastic, more mobile. And it acts like a pulley. So again, we're talking pulley. And this is the fifth point of conflict where the triggering of the finger can happen. And this is, of course, the distal edge of the A2. So distal edge of the A2 is, again, a kind of point where you can see the Camper's chiasm forming. This is, of course, a 3D version, and it's just to bring forth a point again, flexor digitorum superficialis at the proximal phalanx level, splits into two, allows flexor digitorum profundus to become superficial. It pierces through to take its insertion at the base of the distal phalanx. And now, just at the level of A2 pulley, distal end of the A2 pulley, there is this split, as you can see. And just proximal to the proximal interphalangeal joint, there is a formation of that chiasm. You can see this is hammock-like, and the flexor digitorum profundus actually rests on it, and it causes a nice bit of elasticity and movement. Of course, to see, note how the slips of flexor digitorum superficialis actually are very long slips, and they divide again from the chiasm. They divide again, and they're kind of really long, small slips that attach to the middle of the middle phalanx. Now, this part of the understanding of optic chiasm, you can really understand how this would be a point of conflict, if at all there is a triggering which needs to be explored apart from A1, A2, sometimes very rarely A3, but just before you go into A3, this needs to be also investigated. Converting this into a panoramic view. So this is a volar aspect of a finger, and we've taken a long axis here. This is right in the middle, and this is a little offset towards the ulnar side to show you different structures. So we have metacarpophalangeal joint, flexor digitorum superficialis, flexor digitorum profundus. Now we move distally. As we move distally, the flexor digitorum profundus, you can see getting angulated right here with a little bit of an isotropy. This angulation is at the level of distal edge of A2. This is where flexor digitorum superficialis tendon is splitting into two. So this is the superficial portion. And as we reach the proximal interphalangeal joint, this is where they reunite again deep to the profundus. Right here, they unite to form the chiasm. And the proximal end of this chiasm is the point of conflict between the profundus and between the chiasm. So this is the region that you need to keep right at the edge distal end of the A2 pulley. And of course, then the profundus goes on distally to take its insertion at the base of the distal phalanx. Now to come to a little offset. So we're going to go all over again, profundus and superficialis and profundus. Profundus moves again distally, right? And there's this angulation. It again tips and angulates to become superficial. More importantly, this is where the chiasm forms, where the two slips of flexor digitorum superficialis meet again. This is a fat pad, volar plate. So they meet again at this point. And then at the level of proximal interphalangeal joint, they split again. And this is the ulnar side of the slip that takes of the flexor digitorum superficialis that takes its insertion onto the middle of the middle phalanx. So how do we convert this? This is again a very focused view of the Camper's chiasm. This is the fifth point of conflict. Again, the chiasm that forms, volar plate, fat pad, and this of course is the profundus tendon angulating and walking through the slips of flexor digitorum superficialis, A2 pulley, which is definitely thickened here. And that's the point of conflict that we need to resolve. Now, how did I wake up to this? This is a case study of a 31-year-old man, and he came with triggering. And when he came with triggering, a painful triggering, we of course said A1 pulley, and we said that there is a tendon sheath thickening also. So the patient was taken. This is a plastic surgeon who gave me a feedback, and this entire video was taken second day post-op, all right? Because I really wanted to see it with my own eyes. I didn't believe him. And so he released the A1 pulley and he did the tenolysis, the tendon sheath thickening. But he said, Dr. Nidhi, the restriction of the movement of the tendons intra-op was still there. So we had to go and release A2 pulley also. Okay, here this is unrestricted movement, right? They released A2 and they said, we still couldn't find a free movement. And we went to find that the Camper's chiasm was all edematous, stuck to the undersurface of the flexor digitorum profundus. There was a lot of edema, so you can see the edema, which is still there, and they had to do a release here as well. And this is, of course, a little fluid in the tendon sheath because he was second post-op, so we can understand what happened. And I was a little taken aback. Then, of course, we had detailed investigations, and he said that he found crystals that were sitting at the level of the profundus as well as of the chiasm. So the patient turned out to be gout, and we have to be so open to this part of understanding that there can be a rheumatoid arthritis. You can have multiple points of conflict in a trigger finger, in a stenosing tenosynovitis. So let's not just stop at A1 or just the tendon sheath thickening, and this is point case and study proving that. We did all those scans in longitudinal axis. May I just go on a short axis, and I'm going to follow you through from the proximal. So this is from the proximal end, short axis, proximal phalanx, and I'm going to just stop here. So as we did the flexion extension, you can see the, I'm so sorry. Okay, so as we did the flexion extension, we can see the free movement of the two slips at the proximal of flexor digitorum superficialis. And as I stop here, you can see deep to the profundus, there is nothing. These two sheets move in tandem with each other freely, and there is nothing really sitting at the back or deep to the profundus. So I'm just going to start this again, and you can see the movement and nothing sitting at the back. But as I move to the proximal interphalangeal joint, just proximal to the proximal interphalangeal joint, flexor digitorum profundus, two slips of superficialis, they have split. And do you keep your eyes right here? And this is just proximal proximal to the proximal interphalangeal joint, and you can see this tissue thickening, which is the sling that is being formed on which the profundus rests, and this is the point of conflict here. Last one is just an interesting video. This is at the middle phalanx. You can see the profundus, and keep your eyes glued here. These are the two slips, long slips, which separate again from the optic chiasm to take the insertion at the middle of the middle phalanx. So this is one slip, and this is the other slip of flexor digitorum superficialis, and they can be explored in trauma cases. So it's a kind of great way of exploring the slips of flexor digitorum superficialis also. With this, I come to my last slide. And so we know that there is primary involvement of flexor tendon sheaths, primary involvement of proximal interphalangeal joint that triggers, not the metacarpophalangeal joint truly. And the trigger points of conflict are 5, A1, A2, sometimes A3, Camper's chiasm, tendon sheath, and nota's nodule. I'm going to leave you with this very interesting. So this patient was sent to us, painful finger, and the flexion was restricted. He was there to rule out an evolving tenosynovitis. Stenosing tenosynovitis, not so much as a tenosynovitis, which will move on to a stenosing effect. I would love to have your answers from here. This is the video. And where does the pathology lie? At the yellow, at the red, or at the blue? So of course, I will say this is the A1 pulley. I will say that this is flexor digitorum superficialis and the profundus complex, but I will not say what this is. I would love to know your answers. We can discuss if we will have the time. Thank you so much for your attention.
Amazing, Nidhi. And every time I feel I know the subject, you throw something unique and new onto me. And it gets me thinking all the way again. I update myself and keep looking for new stuff. But an amazing talk. Just as an afterthought, have you ever thought of measuring the area of the tendon
Correct.
at the synovium, narrowing and proximal? I found that if the area reduction is more than 50%, you always have stenosis. Have you found something like that to that effect?
Yes, absolutely. So that is another part where they say that A1 pulley thickening point, right, more on the ulnar side. It is said that whenever there is an annular pulley thickening, it is more on the ulnar side, but the total area you see, if it is increased, then we say that it could be going into tenosynovitis. I totally agree. There is a point there, which I was trying to explain through a simpler measure of AP diameter increasing. So once the AP diameter increases, the entire circumference in the area also increases. But yes, that is a point for description and making a greater, a more robust report. Yes, that can absolutely be done. A great point raised.
Okay. Thank you so much, Nidhi. I think if anybody has any questions, we can put them through.
Dr. Nidhi?
Yes.
Yes.
Yeah,
Yeah,
go ahead,
Dr.
Ankit, go ahead.
Nidhi,
Go
can
ahead.
you hear me? Yeah.
I can hear you. Yes.
Yeah.
Yes. Can you just show us again where do you measure the thickness of the pulley? I know you may have covered it, but still, where it's an arch. So
it's the ulnar side. Okay, the ulnar side of the pulley is always more thickened, so you can have the radial side looking absolutely normal, but we have to go on the let me just come up again and share again. All right, so I'm going to go back on it again, and all right, so this is where we are, and I'm going to make a share.
Classes attend karte.
All right, so would you see here? So
yes.
we cannot go all the way down, because if you are we here?
Yes.
Can you see? So
Yes.
we don't really go down. Okay, we can, of course, we see, because there is a lot of edge refraction here. Not only that, the pulley is attached. It actually arises from the volar plate. So the volar plate, so you will be then measuring a part of the Waller plate also. When we come to the ulnar side, it is at the midpoint. So it is at the midpoint between the most deepest edge of the pulley and the central portion. At the central point, ulnar side is the absolute measurement that should come.
Okay. Okay. Fine. All right. Thank you, ma'am.
Any
Ma'am,
suggestions?
No, I mean, I just had this query that where do we measure?
Yeah, we measure it right at the ulnar side is most important. We really don't go down deep. This is a vertical diameter, which we take and drop a perpendicular from there. This was, of course, on the ulnar side and the radial side. This radial side actually seemed a little more thicker than the ulnar side, which was like 0.07 centimeters, which is like 0.7 millimeters, and this was about 0.6. But of course, eyeballing was also an important consideration.
Right.
Okay.
So, do you have a cutoff that you use for thickening of the A1 pulley?
Yes, I do. I do. I found, see, most of the people said that 1 millimeter to 1.2 millimeters, right? That is their cutoff. But believe me, I had a lot of patients fall through the net, and I always take 0.5 millimeters as my cutoff. 0.5, anything greater than that, and then I do a dynamic scan, and if I see that fingerprinting, I do say that we are dealing with a thickened pulley. And then, of course, you can do a side-to-side comparison, which is really important, because sometimes it happens that you have both the sides coming 0.7 millimeters, and you're wondering why one is getting a little more symptomatic than the other. So that is a little challenge, does happen, but my cutoff is 0.5 millimeters.
Okay.
Ma'am, can you discuss the last case you have shown?
Yes, of course.
Last
What are the answers? No. First, give me the answers. Without the answers, I'm
Ma'am,
not.
I've put my answer in the chat box.
You have, Ankit? All right. I hope these guys can see and cheat. All right. Okay. So anyway, just everybody's videos on, and let's have them coming through. Yellow. All right. Thank you, Sandy. Excellent. Hats off. Thank you, Bharat. Can PIP joint synovitis or effusion cause trigger by lifting Waller plate? So there is hardly any involvement of Waller plate. I actually did think through my own practical Meenakshi that I always used to think that a little bit of Waller plate thickening or a tear of the Waller plate can cause trigger finger, but it does cause triggering, but it does not cause stenosing tenosynovitis. That is a very important concept that we have to remember in the evolution of trigger finger. See, there are multiple causes of trigger finger. Yes, Waller plate injury can cause trigger, but when we are talking of stenosing tenosynovitis as a synonym for trigger finger, no, the Waller plate really does not play a great any role in it. So I hope that answer is good enough for you, because this is something that did happen and I did think, and it's a very interesting question that you brought up. Thank you, Vishal. Why is it that I can't see your answer, Ankit, in this? Why don't you come up and tell me what your answer is, Ankit?
Ma'am, can you just put up that slide again?
Yeah,
I think I answered yellow.
All right, let's put the slide again, and it's a very interesting slide. All right, fine, right there. The slide is right there. I would really love to have Ankit, you be the spokesperson for all the rest of the delegates, and if there is somebody who wants to join in, please feel free to put your the mic on and speak out your answer. So you said yellow, so that means you say it is the A1 pulley. Anybody else? Anybody else?
Ma'am, can we see the slide again?
This is the slide.
Yes.
Are you not able to?
Yeah. You'll have to share it.
Oh, I'm so sorry. I'm just really very sorry. Okay. How do I do it? Escape. Yes. So I'm going to come back here. All right. And share screen. Jeremy, where am I? Yes, here I am. All right. Can you guys see it? Are you able to see it all?
Ma'am, is it from the tendon seat? Is it a ganglion cyst, I think?
So let's go one by one. All right. So the yellow arrow is the annular pulley. Then you have flexor digitorum superficialis, flexor digitorum profundus, Waller plate. Right? Are we all good here?
Hmm.
Yes.
Perfect. And then this is the nerve, interdigital nerve. Do you agree?
Yes.
And this is the interdigital artery.
Artery.
Perfect.
Yes.
So what is this? Okay, so this,
Lumbrical.
it cannot be.
Lumbricals.
Oh.
It cannot be lumbrical. It cannot be lumbrical.
No?
Think again. Why? Why? Lumbricals don't take a radial attachment. Their
Oh, it's
attachment
from the
is,
radial.
yeah. So they all take, so the introsci that all take radial attachment. They don't take, what takes ulnar attachment? Lumbrical introsci, you're absolutely right. This was a complete tear. All right. This was a complete tear with the tendon that you can see here. But what is it? Lumbrical, introsci? If introsci, which one? So you have to understand that all the attachments of palmar, introsci, lumbricals, all of them are on the radial side, except dorsal introsci. Dorsal introsci takes its attachment on the radial side, and this was a tear. And you do know that dorsal introsci, what do? Dab. They abduct the finger and they cause flexion at the metacarpophalangeal joint. They assist in flexion at the metacarpal. So look at this video again. See what's happening. He can flex at the interphalangeal joint, but it is at the metacarpophalangeal joint that there is a restriction. So they cause flexion at the metacarpophalangeal joint. This was a complete tear of the dorsal introsci. This was not stenosing tenosynovitis developing. Are we convinced?
Yes.
Good. Thank you.
Excellent.
Perfect.
Uh,
So
Ma'am,
we do have,
one more question.
yeah, sure.
Yes. Ma'am, do you have a checklist for what all things you would look for while scanning a patient who has been clinically diagnosed with trigger finger? I mean, the diagnosis is there.
Yeah.
So do you have a checklist that what all things you will look for?
Yes. What is happening? Why can't I escape? Give me a minute. Yeah. Okay. All right. Coming back again. Have I stopped sharing?
Yes.
Yes.
Yes. All right. Okay. So the checklist. Would you want me to go? I'm not going to go share the slide, and let's save some time here. So trigger finger. Oh dear, there's something that is happening. All right, let's leave it at this. So for a trigger finger, grayscale static image, I go from the metacarpophalangeal joint and I go entirely up to the insertion of the profundus tendon. Just very important. There is a case which I truly missed and I could not get it out of my archives, where I found that even the cruciate was involved. Okay, the C2 was involved. And I couldn't find it because I could remember that, yes, I missed that one. So we go entirely through the entire length. We know that A1 is most commonly involved. At A1, we know that at that metacarpophalangeal joint, it is the flexor tendon sheath thickening that is involved. And also the tendons go into a reactive tendinosis. So I need to see my A1 pulley at metacarpophalangeal joint. I need to, and this is, I'm talking static scanning. Then we need to see our tendon sheath thickening. So we have to go in a long axis as well as in a short axis to see, are we missing a tendon thickening? And the third point is that we need to see for the tendinosis, the tendons. So we have to do a side-to-side comparison. I usually don't go on the other hand. The side-to-side comparison between the two fingers is good enough for us. When we are done with this and we find, all right, so it's the A1 pulley involved and it's the flexor tendon sheath involved, I move on to the A2. When I go to my A2 pulley, that's when I start doing my dynamic scan. And with the dynamic scan, the fingerprinting can be seen both proximally as well as distally, as well as at A1. When I do my dynamic scan, and if I see that imprinting, that fingerprinting, I am certain that this patient is in that evolving stage of stenosing tenosynovitis, pain or no pain. Sometimes these patients come with recurrent tenosynovitis, right? This Hi, can you hear me?
Yes.
Yes, yes,
Yes.
I'm
Yes.
so sorry, I have a very unstable. Yeah, all right. So once I'm done with this, this tear of the dorsal interosseous happened that he did have a locking. And he forcefully opened it. He extended his finger and he says, since then, the pain won't go away and I'm unable to flex my finger. So there are multiple things that overlap. So I go to my A2 pulley and that's when I do my dynamic scan. And that gives me a very beautiful perspective of my entire A1, common A2, flexor tendon sheaths and the tendons. Following which, because it's a small footprint, I do it with a linear array. You cannot really see this with a linear probe. You can, but then you will need to be extra careful and mindful of what all you need to see. Following that, I go to my proximal interphalangeal joint. Now, the proximal interphalangeal joint is the fifth point of conflict. Everything, most of the things of stenosing tenosynovitis lie between proximal interphalangeal joint and the metacarpophalangeal joint. So that's where we have the campus fascia, and the campus fascia is always best seen in long axis scan on a dynamic scan. So once you see your fifth point of conflict and you say everything good, you can just go for a completion of the report right up to where the profundus is taking its insertion. And that's when I say that stenosing tenosynovitis is over. For me, that's where I say this is where my interrogation ends. If
Wow.
anybody else has any
Okay.
other experience,
Yes.
please feel free to join in.
No, I think that's quite a comprehensive checklist. I mean, I think it's
Perfect.
completes everything. Yes.
Yeah,
Thank you, ma'am.
it's very interesting. This entire concept actually came through a plastic surgeon. He was an eye opener to me, and he said that no, it doesn't matter, Dr. Niti, it doesn't matter whether you missed A2 or not, but it helps us because we go prepared. We counsel the patient. And we go prepared and we tell him that there are multiple points of conflicts which we will have to release for you, and your recovery is going to take longer. You see? So it's all about, see, surgeons really don't, in true honesty, surgeons don't really need us, but they need us where? They need us to prep themselves before going in the OT. And that preparation gives them the confidence to do a good job. That's where we become the pillars of strength for him. And so it was an amazing chat that day. And this diagram that is drawn by him.
Oh, wow.
The flexor digitorum and the split. And that's how he went on and we recorded it. So it was a great learning point for me as well. Okay, do we have some time for Karthike, for the thumb? Karthike?
Yes, ma'am. Yes, ma'am.
Should we go ahead?
Yes, ma'am. Actually, due to some reasons, I lost internet and I'm connected to my phone. So I'll try to be as fast as I can so that there is no glitch.
Okay, all right, don't worry. We will be very patient.
So shall I start, ma'am?
Sure.
Okay. So is my screen visible?
You are very happily visible.
I'm trying to connect to ma'am.
Don't worry. Any questions, Upasana? Anyone? I'm sorry, I'm trying to look through the questions. Thank you, Neeti. Thank you, Uma. Thank you, Prasanna. Thank you all for joining.
Ma'am, should we look for other differential diagnosis?
Yeah, of
You don't
course.
find anything, but the finger is still triggering.
Absolutely. Very good
Uh,
point, Upasana. So that ganglion cyst was one of them. And that ganglion cyst does cause triggering, but it is not a part of stenosing tenosynovitis. And then you can have sesamoids. Thumb sesamoids are a very important part. Dupuytren's contracture, which is one of the
Yes.
major differentials for stenosing tenosynovitis. So what is the difference? So Upasana, I'm going to come back to you. So what is the difference? How would you, I'm not talking clinically, but on an ultrasound, how would you say that this triggering is not because of stenosing tenosynovitis in Dupuytren's? How would you know? Ultrasound wise, how will you differentiate between Dupuytren's and stenosing tenosynovitis?
Ma'am, I think Dupuytren will involve the flexor retinaculum, basically.
The palmar retinaculum.
Palmar retinaculum, and
Yeah,
that
yeah.
it is more common in A1 poly thickening, in trigger.
Palmar fascia involve करता है. Palmar fascia से बहुत late stage के अंदर. We are talking early difference. See, I tell you, and I think it's a message that I would like to give to everyone here, which I learned that कोई भी चीज अगर clinically diagnosed हो रही है, then we have missed the boat as radiologists. So I'm talking of very early Dupuytren's. I'm talking when there is a conflict in the surgeon's mind, whether it's stenosing tenosynovitis or it is Dupuytren's. Where is that point where you would say, that, you know what? Yeah.
Hello.
Okay, Kartikeya,
Yes.
are you ready?
Hi. Yes.
Okay, Upasana,
Uh,
we'll come back to our discussion.
Okay.
Yes, please. Go right
yes, ma'am.
ahead.
My screen is visible, right?
Absolutely.
Yes.
So wonderful talk, ma'am. So I'll just add on to your points as far as the thumb is concerned. So we are looking forward to the same entity, but at a different place, because a little bit anatomy at thumb is different as far as the pulleys are concerned. So as you told that this is basically a stenosing tenosynovitis. So we are looking forward to a case of stenosing tenosynovitis of flexor pollicis longus. So as far as I don't know why my projector is not working, but still, so flexor pollicis longus tendon is the medial-most tendon, is the radial-most tendon, which is on the flexor aspect of the thumb and is responsible for the flexion as far as the thumb is concerned. So this is how the usually pulleys of thumb are arranged. We have got A1 pulley at the proximal interphalangeal joint. Then we have oblique and annular pulley complex, which we usually call as pars obliqua and pars annularis. And then at the distal interphalangeal joint, we have A2 pulley. So as far as the case is concerned, this is a complete panoramic view, conjoint panoramic view. And I'll just try to get the, actually I'm using Mac for the first time and I don't know how to get with the presenter. But on the proximal most aspects, there is a thickened pulley. I'll just, here is the thickened pulley. I'll try to do it this way. There is a thickened pulley, and this is the flexor pollicis longus tendon. And what I found with this particular case is that a little bit inhomogeneity as far as this location is concerned, which is basically the location of oblique pulley. So when I evaluated more at the proximal interphalangeal joint, there was crossly thickened pulley in the longitudinal section, in the transverse sections, and with the power angio mode, I find a little bit of vascularity. Similarly, when, as ma'am told, I calculated on all the three different aspects, on the ulnar aspect, radial aspect, and the anterior aspect, I found all the thickness to be a little bit varied, with radial most being the most thickened, which was 1.6 mm. And when I evaluated the tendon in a cross section, so this was a thickened A1 pulley with a little bit of vascularity. And as I moved more distal, there was thickened oblique pulley also, but there was no vascular pickup. It didn't show any signs of inflammation. So as far as the types of thumb pulleys are concerned, there are 4 different categories. Next, I'm going to show you 4 cadaveric analysis of the types of pulleys. So we have, this is primary complex, which is the least common one. We have A1 pulley, the oblique pulley, and the A2 pulley, which looks like this way. Then we have type 2, which is A1 pulley and oblique and annular pulley complex, which are fused together, and the A2 pulley. Then we have completely separate all the 4 pulleys, which is A1 annular complex of oblique, completely oblique pulley, and the A2 pulley. And the type 4 is the fused fibers of A1 and the annular pulley of oblique pulley, and the oblique pulley itself, and the A2 pulley. So that's how we have to evaluate the thumb as far as the whole thumb is concerned. So showing you that this particular complex was the A1 pulley, which was the primary cause of the triggering, and the oblique got secondarily affected because of the continuous overexertion over this flexor tendon. So with this, this was one single case which I presented. And I really apologize for the technical glitch from my side. Sorry, ma'am, and thank you.
Amazing, Moss. Amazing. Wonderful demonstration. Very good images.
Yes, I think the images are fantastic.
Yeah, very good images. Keep it up.
Thank you, sir. Thank you. Thank you, sir.
That was really nice, Karthikeyan, about
Thank
the
you, ma'am.
weekly. Very, very nice demonstration. And next time I'm going to try and see that oblique pulley, whether we can see that oblique pulley or not. But yes, of course, A1 and A2 is something which, of course, we all can.
Yes, ma'am.
And that tendinosis was great catch that you found.
Thank you, ma'am. Thank you.
Right, okay. Ankit, we'd request you to please come up with an amazing presentation. You do have one.
Yeah, so I have, no, amazing or not, I think it's your call. You will have to decide. So just a moment, please. Yes. All right. So if I screen visible? Yes.
Yeah, yeah.
Is my screen visible?
Yes, yes.
Yes.
Yes. Okay. Super. All right. So we have this 63-year-old male with intermittent locking of the middle finger. He's right hand dominant. He has history of diabetes almost in the past 21 years or so. He has an ESR of 12 and a CRP of 7.4. Now, he has been clinically diagnosed with trigger finger, but today when he walked into the department, he said, "Doctor, there's no triggering happening." But because I took my anti-inflammatory today morning. So this is what we see at the level of the A1 pulley. All right, the middle finger is triggering. So although the pulley looks significantly thickened, or rather there's asymmetric thickening, you see that there's some thickening happening over here as well. All right. So this is a FDS, that's the FDP, and that's the thickened A1 pulley. So it's almost 2.7 millimeters thick. So the first time, I took a section, and that's what I said, okay, let me measure it over here. Then what we do is when you go slightly more proximally, now how do I know this section is slightly more proximal? It's just that I'm not seeing the volar plate over here at all. So what I see over here, it's slightly more proximal. You see just the proximal edge of the pulley, and you see another soft tissue, which is seen over here. So this is typically the location of the palmar fascia, and not showing too much of vascularity, or rather it's almost avascular. But if you palpate over that region, you will see that there's a palpable nodule over there. So this is what we see. So apart from a thickened pulley, we also see a nodule over here. And as I go from proximal to distal, this is the FDS, this is FDP. Okay, I'm just going to go back, and again I'm going to see, and that's the thickened nodule, which we see from the most palmar, most or the superficial most fibers of the A1 pulley. Again, as I go from medial to lateral, this is what you see. These are the tendons. And as we come over here, I see another ganglion, all right, at the distal edge of the A1 pulley. I see a ganglion, but it's an exophytic ganglion. It's not doing anything significant, but yes, it's a finding in a patient who was diagnosed with trigger finger. Again, we put our probe on the long axis, and this is this approximate location of the A1 pulley. But this is another soft tissue which we're seeing. So it's a hypoechoic plaque-like soft tissue just below the skin and just sitting on the flexor tendons, and it's in absolute close proximity with the A1 pulley. So this corresponds to that hypovascular soft tissue which we saw on the short axis images as well. Again, when you do a dynamic scan, you see that's the A1 pulley, and this is a soft tissue over here. But if you see there's not much triggering happening over here, the tendon is gliding pretty smoothly. And see, that's the A1 pulley, and that's the nodule. So we thought that this is a Dupuytren's nodule that we're looking at. Again, so in a known case of trigger finger, what we saw is a thickened A1 pulley that is asymmetric thickened. We saw an exophytic ganglion arising from the distal edge of the A1 pulley, and we also saw a Dupuytren's nodule. So if you go up in the literature, or even you talk to the surgeons, they say that there's a significant association between stenosing tenosynovitis or trigger fingers and Dupuytren's contracture. So if you have a patient with A1 pulley, it's a good idea to at least palpate the palm and look for a Dupuytren's nodule. Or if you have a patient with Dupuytren's nodule, it's a good idea to just ask the patient that is there any kind of triggering happening, or maybe you can just go ahead and look for a subclinical trigger finger. So basically, the pathology between both is the same, just that in trigger finger, what you have deposition of collagen in the A1 pulley, all right? And both of them have a strong, at least in our country, there's a strong correlation with diabetes mellitus. Same thing in Dupuytren's contracture, there is myofibroblastic proliferation of, again, type 3 collagen. So these are the two, pathologies which can coexist together. It's a good idea to do a little bit of clinical correlation yourself, and so that if the surgeon goes in, there are no surprises. It's very unlikely that a hand surgeon might have any surprises. So in fact, the reason why they might send it to you is, hey, you know what, this patient has a trigger finger, but I'm also palpating a nodule over here. Can you tell me, is it a Dupuytren's nodule, or is it a ganglion associated with a thickened A1 pulley? So your role as a radiologist is to differentiate between the two, and just help the surgeon out with that. So thank you so much. That's the short case which is there.
Oh, Ankit.
Amazing.
But just tell me, how sure are you of to say it is
Yes.
Dupuytren's nodule?
Hello?
So how sure would you be to say it's a Dupuytren's
Hello?
nodule? Can you hear me? Am I audible to all?
It's yes. First of all, it is clinically palpable. It is at the location, that's the most common location for a Dupuytren's nodule. Typically, the thickening of the palmar fascia in a Dupuytren's nodule or a Dupuytren's contracture typically begins just at the level of A1 pulley or at the proximal edge of the A1 pulley. That's a very, very common site. And the clinician has diagnosed it for me. All I have to do is tell him, is that a ganglion or is it a nodule?
Okay.
So my take on this, Mohit, that Dupuytren's nodules are usually very vascular. So I would always, so if it is, so A1 pulley, when it gets thickened, and we are talking of stenosing tenosynovitis being a cause of A1 pulley triggering, then also you will raise some sort of vascularity. But in Ankit's case, there was a little bit of a distance that we could see between the A1 pulley and that nodule. So if I would put in that palmar fascia so superficially placed, if I put my Doppler and if I raise vascularity, I would be 200% sure we're dealing with Dupuytren's.
But will all Dupuytren show increased vascularity?
Most of them. It's
Ah.
like the studies say almost 89% would show. And that is one of the differences where you need to differentiate between the stenosing tenosynovitis, which is a very big overlap between the stenosing tenosynovitis and Dupuytren's. But if it's a focal nodule, it's a focal nodule. And as he said, you could palpate it. So when you move your probe over it, it actually jumps over. You can actually feel the bump underneath your probe, and you put your color Doppler, and if it is away from that line of A1 pulley, then definitely it's something that makes you believe that we need to really search for the cause of Dupuytren's there.
So,
Okay.
Dr. Mohit, so what happens is, suppose it depends on what time you're imaging the Dupuytren's nodule. Has it been there for a long time?
Yeah.
It has formed. So once it's formed, maybe the vascularity will go down, partially treated. Diabetes is under control. It might happen that you might not see vascularity. And yeah, so early phase, early nodules,
Very
painful
important
nodules. So these are the times when you might see increased vascularity. And of course, a lot also depends on what the probe settings are. I mean, that's very essential because this is something very superficial as well. A little bit of extra pressure and all that vascularity will go away.
You would be doing that with the 24 megahertz now, isn't it?
Yes.
Good
No,
question.
but okay, let me tell you this. Okay, I have a 24 megahertz, I also have a 18, and I also have a L3. But for some reason, for some reason, that L312 also has fantastic vascularity. Sometimes I feel it is more sensitive than the 624 as well. So you have to see everything and
by physics, if you go by laws of physics, the more the frequency of the probe, the better should be the vascularity.
yes, that's it. But it's different. Maybe I can show a few cases. I mean, next time where I feel the vascularity is more in that other. But yes,
Yeah.
I can't
Right.
explain.
Okay.
Sir, I have a question. Can I ask?
Sure.
Yes.
Go ahead.
Yeah, sure.
So yes, sir. So by the term, it's Palmer fibromatosis that we usually call as Dupuytren's contracture. I have seen few of the cases, but none of them showed me vascularity, because I think they were more of a prolonged cases or the chronic cases with more fibrosis. My question is that if it is a Dupuytren's nodule, how can we differentiate it with if it's showing vascularity with the glomus tumor or entities like painful nodules with the vascular ones?
Clinical correlation.
Yes.
You have to see at what point is the flexion happening. See, one of the reasons why tenosynovitis, we keep saying triggering at proximal interphalangeal joint, stenosing tenosynovitis. In Dupuytren's, it is the flexion which is affected at the metacarpophalangeal joint. And so if you have seen a Dupuytren's contracture, there is a pull which comes from the proximal interphalangeal joint, goes through the metacarpophalangeal joint, and the patient is in a position like this, and look at what happens to the ring finger. So that is where your clinical correlation has to come with that nodule. Nodule ke to palmar fascia nodules are multiple, not only glomus, but even the tendon
Yes, ma'am,
thickening.
exactly.
So, there are bursitis that are sitting there. So those kind of changes, you have to have a clinical correlation and then see what is happening to the ring finger. What happens to the ring finger?
There's a contracture like band, and it's a mid-flex position usually maintained at the MTB joint.
And
MCP
usually,
joint.
yeah, it's the two fingers involvement. Like here, it is not necessarily, but yes, I think the clinical correlation at this point is very important. And then, of course, as Ankit's presentation said, that can be anything. So when there is a vascularity or no vascularity, glomus is something that you would definitely need to wait and watch. When it comes to Dupuytren's, you just need to give a shot of steroid and see if it improves.
And I think, ma'am, that is the differentiating point we were discussing.
Yeah, exactly.
Yeah, the flexion of the metacarpophalangeal joint in case of palmar
Correct.
fascial nodule.
Correct.
And
Absolutely.
yeah,
Absolutely. Deuterans has got metacarpophalangeal joint, which just doesn't move. And what is the difference? How I do my deuterans is I ask the patient to put the palm on the table. Okay? I ask the patient to put the palm on the table. If it is stenosing tenosynovitis, then the finger flattens. But if it is deuterans, it still remains like this. It will never extend. That gives me the clue that we are dealing with deuterans. We are not dealing with any other lesion, whether glomus or a ganglion. Just ask the patient for the deuterans to put the hand flat, and the patient will not be able to straighten. All the fingers will straighten, except the finger that is involved. It will still remain in a flexed position because that band doesn't let it extend. That's the clinical correlation.
and also, ma'am, the nodule of trigger finger, it will move with the movement of the PIP joint, with the
Totally.
movement of the PIP joint, but the other nodule will not move.
That's a very good point.
Yeah.
Perfect. That's a very good point. The dynamic scan will help us to differentiate whether it's a palmar, because the palmar nodule will not move. But yes, with the glomus and deuterans, that definitely will be a challenge. But I have yet to see a palmar glomus. Anybody seen a palmar glomus?
No, not yet.
Is it documented? That's a good point. We'll Google today. Of course, glomus can happen anywhere. Absolutely. It can be a bone glomus also. So there is a huge probability. I think it is a food for thought that everyone will take back home today from this. We'll all do our research to find out if it is a vascular lesion and there is a deuterans which is vascular, and then A1 pulley of the tenosynovitis which is vascular. How do we differentiate between all of them to give a robust diagnosis? Good point, Karthike.
So, another thing for glomus is glomus tumors are extremely tender. I mean, the patient won't be coming with such a huge, at least, in our kind of setup, they will not wait for so long.
Correct.
So that's one thing. And if I would just go back to the actual images which I have, there's a lot of, if you look at it, it's a very irregular kind of lesion. It is kind of blending in with the fibers of the superficial fibers of the A1 pulley. So very irregular margins. Otherwise, if you look at glomus morphology, it's a well-defined lesion, kind of rounded, unlike the Dupuytren's nodule. It's just fascia which is thickened.
At one point, when you showed the first slide, Ankit, I really thought that it was a penetrating injury sitting there. It actually went so superficial that I really thought that was that a penetrating injury, post-traumatic tenosynovitis developing?
Yeah, so maybe I can just go back to that one slide and I can show you what I'm trying to say is, if you look at this image over here, it's a very irregular, like an infiltrate, like how you would see a Byrad's 5 lesion, which kind of goes into this fascia over here. Otherwise, and it's kind of also blending inside into the superficial fibers of the A1 pulley. So if you look at a glomus tumors are generic. I mean, unless malignant, they're not so ill-defined or an infiltrative nature. They're more rounded. If you see histopath image, the intraop images, they're more lobulated. Yes, maybe a little bit of rounded, but they have cleaner margins compared to this. And there's absolutely no speck of vascularity in this. Yes, you can have 30% of glomus tumors which are hypovascular, but there's absolutely no vascularity and no tenderness on application of probe. No probe tenderness.
Absolutely. Totally. Perfect. That's a great one. Yeah. So
I think. Yes.
What is about congenital trigger finger? Is it different in children?
Congenital trigger finger versus the trigger thumb.
Yeah.
Trigger thumb. No, so we have to go back to the congenital part of the trigger finger or a trigger thumb. What is the pathology? why does that triggering happen? That triggering happens because for some reasons, the growth of the tendons is far exceeding the growth of the tendon sheath.
Yeah.
Whether it's the thumb or it's the finger, that is the pathophysiology. Now, that tendon sheath, which has not grown synchronous to the growth of the tendon, diameter-wise, leads to constriction over the tendon that causes thickening, focal thickening of the tendon. So the triggering will be there. But for us to say that will that be a stenosing tenosynovitis is not the thing. Nota nodule is a trigger thumb. It is a trigger finger. So that means there will always be a restriction of extension. Now that restriction of extension is what we transfer into what we call as early phase of triggering, or there could be a locking also, persistent flexion also. So yes, the pathophysiology is the same. It will be a focal tendon thickening that will be sitting also in the finger when we are talking congenital trigger finger.
But the pulley is normal.
The pulleys are
Histologically
no,
also it's normal.
the pulleys, it depends upon where exactly that constriction happens. If it happens at the level of the pulley, so it can happen at any point. It's not that it will happen only in a certain region. Normally it happens proximal to the A1 pulley.
Yes.
The nota nodule or the thickening or the constriction is always proximal to the A1 pulley.
Okay.
Okay, I think that's a fantastic discussion. Ma'am, I think if you don't have anything to add, we can end this session over here.
Absolutely, yes, totally.
Great, great.
Thank you all. I hope that everybody had a great
Thank you so much.
time.
It is completely new for us. The drawing is shown now. You have to read it again.
Thank you, Pastor.
Thank you so much. Thank you so much.